Today I will be talking about surgery for brain metastasis, when and in whom. Uh, so coming to brain metastasis, metastasis are more common brain tumors. These are 3 times more common than the primary brain tumors themselves. Lung, breast, melanoma, and colorectal are the most common cancers that metastasize to brain. And the incidence is increasing because of better therapy which is available and patients living longer, as well as the new imaging modalities which are available to screen these tumors. So coming to survival in patients with brain metastasis. So if left untreated, the survival is just a month. So from 1950s to 1980s, when whole brain RT was the treatment, the survival was 3 to 6 months. And now, over the years, with improvement in therapy and targeted therapy, the survival is now few years. However, having brain mets has an overall poor survival at 2 years, which is less than 6%. So, coming to prognostic classification of brain metastasis patients. So, this classification tells you how much a patient will survive based on the clinical factors. So this was based on recursive partitioning analysis of 1,200 patients in the 3 RTOJ trials with brain mets who received WBRT, whole brain RT. So the worst performing group was class 3 who had KPS less than 70 irrespective of the other factors, and they survived for 2.3 months. The best surviving was the patients who had KPS more than 70, age less than 65, with controlled primary and no extracranial metastasis, and they survived for 7.1 months, and the rest of the patients were classified in class 2 and had an average survival of 4.2 months. So what we are seeing now is the majority of the patients are now in class 2, which makes the treatment options slightly difficult. So coming to surgery is a local therapy. It aims to control intracranial disease. However, the load should be low and the disease should be localized, and it also improves to maintain the patient's neurological status. It aims to prevent deaths due to neurological causes. However, one thing to understand is that it cannot affect the systemic disease and prevent deaths due to systemic progression. So surgery is best suited for RPA class 1 and select cases in class 2 patients. So this is the RPA class. So you can see this is the class 1 for which surgery is best suited, and few select patients in class 2. So which type of brain mets respond best to surgery? So either it's solitary mets or oligo mets or multiple mets. So coming to solitary mets, so there were 3 randomized trials which were done in 1990s, which subjected a patient with a solitary brain met to either whole brain RT or surgery followed by whole brain RT. And the patients who had surgery followed by whole brain RT had a survival advantage. And this was seen in a patient who had good control of extracerebral metastatic disease and were in good KPS. So this is class 1 evidence for solitary brain mets that surgery is useful. So is surgery better than SRS for solitary brain mets? So there is no level 1 evidence to support one over each other. There is level 2 evidence that both are equal in efficacy. And there is level 3 evidence that you can use SRS as an alternative to surgery plus whole brain RT, provided there is ready availability of resources to detect recurrence and salvage therapy. So coming to the other question, is surgery indicated in multiple brain mets? So generally surgery is not preferred. However, there are a few studies which have shown benefit after complete resection of 2 to 3 mets. And these are usually in patients who have a less systemic disease than their RPA class 1 patients. However, the evidence is not robust. So is surgery indicated for recurrent metastasis or progression after SRS? So again, surgery, there are a few case studies which show that you can do surgery for recurrent metastasis. However, these are again in good class 1 RPA patients who have limited systemic disease. However, a thing to remember is surgery is difficult in previously treated patients and a proper case selection is necessary. Coming to surgery for recurrences after SRS, again, one of the studies has shown that it increases the overall survival. However, these patients should have limited systemic disease, that is class 1 or class 2 RPA patients. Coming to what is the role of surgery in lung cancers. So lung cancers can be driver mutated or non-mutated cancer. So in driver mutated cancer, the role of local therapy is being questioned now. So there is prolonged survival with targeted therapy, and the side effects of local therapy become evident. So a proper choice of local therapy is required. Also, brain mets are more common in driver mutated lung cancers. So coming to the type of patients, if you have a solitary or a dominant met with impending herniation, then surgery is definitely required. If at the onset you get an operable primary with a solitary brain met, then again surgery is recommended, because you will be able to sample the primary as well as the metastasis from the brain and see their mutation status. In brain mets with advanced cancer, you probably could give systemic therapy. For asymptomatic solitary brain met with driver mutation, again you can give systemic therapy. So for a patient who has only intracranial progression on a TKI, the options will be you can put him on a higher level second line TKI. If it is not available for any reason, then surgery is an option if the disease is limited, or RT if there is a widespread disease in the brain. For progression in the intracranial and extracranial compartments, probably a biopsy from extracranial compartment, and then you can decide how to treat this patient. For non-mutated patients, it is how the protocol is how you treat a regular brain metastasis patient. Coming to surgery in leptomeningeal disease, there is no role for surgery. However, Ommaya reservoir can be placed, as it is a less painful, it gives a less painful CSF access to give chemotherapy and sample CSF. So which patient should be sent for a surgical opinion? So again, the same thing, that controlled or stable primary with no extracranial mets. KPS should be more than 70, age less than 65, preferably a solitary met, and symptomatic with mass effect even in driver mutated lung carcinomas. So the treatment decision, the surgeon decides whether the site is eloquent or not, and what are the surgical risks for the patient. And the final treatment decision can be taken in a joint clinic with pros and cons of alternative treatment modalities. So just coming to a few case scenarios. So where surgery is indicated, you generally need the patient to be in good performance status and controlled primary. So a solitary brain met which is causing mass effect and which is in a non-eloquent area, or a solitary lesion with unclear diagnosis, or a metastasis from a radio-resistant tumor, surgery is definitely indicated in these patients. So second scenario is where surgery is not preferred. So again, the patient is in good performance status and controlled primary. However, the tumor is very small or in an inaccessible location. Secondly, if the tumor is in an eloquent location, which is basal ganglia, brainstem, motor cortex or speech cortex, this tumor is located here on the motor cortex and is definitely not an ideal surgical candidate. So the options in these patients could be SRS for tumors less than 3 centimeters. The scenario where surgery is not at all indicated is in a poor performance status, uncontrolled primary, and in a patient with multiple brain metastasis. So again, the clinical scenario with driver mutation, this is what we just had gone back. So just to show you an example, this is a 66-year-old female ALK positive metastatic adenocarcinoma, was treated with crizotinib, partial response for 1 year. This patient developed progressive disease in the lung and solitary brain metastasis, but she was unaffording for the ceritinib therapy. So the treatment was planned was RT to the lung and excision of the brain met followed by radiation to the brain. So you also need to remember that you could have alternate diagnosis which you think as metastasis may turn out to be an abscess. So this also needs to be kept in mind. And coming to the surgical techniques, 46% of patients will recur locally. So an R block resection is favored over piecemeal resection, and some authors have advocated removal of even 5 millimeters of normal parenchyma after the R block resection. So to summarize, surgery is indicated in patients with solitary symptomatic non-eloquent brain mets, in patients with good performance status and controlled extracranial disease. The role of local therapy is challenged with the emergence of highly effective targeted therapy in driver mutated lung cancers. Treatment decisions can be optimally made in a joint multidisciplinary clinic. Thank you.